Hello everyone, and thanks to the organizers for giving me this opportunity to present the papers about target IORT, which is comparable to external beam radiotherapy. So this was first of kinds of paper where long-term survival and local control outcome from a single dose targeted intraoperative radiotherapy during lumpectomy for early breast cancer was compared. Now, the objective of this study was to determine whether risk-adapted intraoperative radiotherapy delivered as a single dose during lumpectomy can effectively replace post-operative whole breast external beam radiotherapy for early breast cancers. This was a prospective clinical randomized RCT, and there were 32 centers in 10 countries in UK, Europe, Australia, and United States and Canada. Almost over 2,200 patients with a woman. Criteria was woman aged more than 45 years with invasive ductal carcinoma of 3.5 centimeter size. That was the maximum size which was taken. N0, N1 disease were stratified into 1:1, block stratified by the center to either risk-adapted targeted IORT or external beam radiotherapy. Now, random allocation was to EBRT, which consisted of a daily fractionation that was either hypofractionation or a conventional fractionation to whole breast radiotherapy or the target IORT arm. The target IORT dose was almost 20 grain single shot, and the target IORT was given immediately after lumpectomy under the same anesthetic sedation, and was the only radiotherapy for most of the patients, almost 80% of the patients. But there were few, almost like 20% of patients who did receive target IOT supplemented by EBRT. Basically, they did undergo target IOT and then had EBRT post-operatively for unsuspected high-risk factors like multiple nodal disease, margin positive, or probably grade 3. Now, the results of this trial was the target IOT was non-inferior to EBRT as taken in the objective. The local recurrence at risk at 5-year complete follow-up was 2.11 for target IOT compared with 0.95 for EBRT, which was not statistically significant. Under the long-term follow-up of almost 8.6 years, no statistically significant difference was found for local recurrence-free survival, mastectomy-free survival, distant disease-free survival, overall survival, and breast cancer mortality. You can see the corresponding statistical values where confidence interval is all more than 1 and p not being significant in each of these parameters. So single-dose target IOT during lumpectomy was an effective alternative to EBRT with comparable long-term efficacy for cancer control and lower non-breast cancer mortality. The target IOT should be discussed with eligible patients when breast-conserving surgery is planned. Now, moving on to the next paper, this was basically a phase 2 of that paper where they looked at the predictive markers, or probably which are those subgroups. They analyzed the clinical and the biological information of the targeted randomized trial of targeted intraoperative radiotherapy during lumpectomy for breast cancers. Now, the target A trial, coming to the introduction, the targeted trial reported a risk-adapted targeted intraoperative radiotherapy, that was target IORT, during lumpectomy for breast cancer as an effective or as whole breast external beam radiotherapy. This study is a detailed analysis of the same, where they looked into different parameters which would be responsible for giving supplemental EBRT apart from target IORT. Now, in total, again, 2,298, as suggested in the previous paper, more than 45 years and tumor size not more than 3.5 centimeters were randomized. And they analyzed the impact of tumor size, grade, ERPR status, HER2 and lymph node status on local recurrence-free survival and of local recurrence on distant relapse and mortality. They analyzed the predictive factors for recommending supplemental EBRT, that's what I said, after target IORT as a part of risk-adapted approach using regression modeling. And if you look at the results, local recurrence-free survival was no different between target IORT and EBRT in every tumor subgroup. That made no impact or no difference if you had considered the ERPR status, if you had considered nodal status, or if you considered the margin status. Irrespective of that, there was no statistical difference between target IORT group and EBRT group. And unlike in EBRT arm, local recurrence in the target IORT arm was not a predictor of high risk or distant relapse or death. This was based on a predictive tool for recommending EBRT post target IORT. Non-breast cancer mortality was significantly lower in the target IORT arm, even when patients received supplemental EBRT. The hazard ratio was 0.38 and the p-value was 0.0091. Now, in conclusion, I'd like to say that target IORT is an effective as EBRT in all subgroups. Local recurrence after target IORT, unlike the EBRT, has a good prognosis, and target IORT might have a beneficial abscopal effect. Thank you.